Hello and welcome to How to Manage Respiratory Illnesses in Congregate Living Settings. This will go into some depth of the management of respiratory illnesses within your non-long-term care, non-retirement home congregate facilities. Our team will present how these changes may look in your facility and how COVID and other respiratory illnesses will be managed moving forward. This was presented and recorded in early November 2022. Our session today is specific to our congregate settings that are not long-term care homes or retirement homes. COVID-19 is now captured under respiratory guidance and is not being treated separately from other respiratory illness guidance documents. So our current fall, we have already seen a spike not only in COVID, but also influenza A, RSV, and adenovirus. Today, we're going to do a quick overview on respiratory illnesses, what facility reporting requirements are, and how IPAC measures or outbreaks are going to be managed within our facilities. We're not going to go into depth of these specific measures as everyone has already had this type of training, but rather how the measures have changed and how they're going to look in our facilities now, and a recap of some of the challenges we have had with them. At the health unit and with our ministries, we tend to use a lot of acronyms, so we have started to collect some of them here on this slide, just in case any of them are new for you. Respiratory illness season. Fall to early spring is when we spend the most time indoors. It means we're in close quarters, and this allows diseases that spread through droplets to spread very quickly. Therefore, we always see a spike of respiratory illness within our region during these months of the year. Respiratory illnesses are also common within our congregate settings. This is due to the close living quarters, many shared common indoor areas, and then there are residents themselves, so they have a lowered immune system typically due to age or their health. We typically refer to this time period as the flu season. However, influenza and COVID are not the only diseases that spike during this time. Other common respiratory viruses are influenza A and B, which locally we have seen a big spike in influenza A very early this year, enterorhinovirus, coronavirus, which would include COVID-19, respiratory syncytial virus, or also known as RSV, parainfluenza, and metapneumovirus.
How to prepare ahead of time. Preparedness is key. I think we can all appreciate this when it comes to preventing or preparing for increased cases or outbreaks. It allows those involved to understand and implement the process quickly, efficiently, and under less stress. Some of the ways we can prepare ahead of time are as follows. Policies and procedures need to be updated. Minimally, this should be done annually to ensure no changes have occurred. With COVID, we obviously have been updating more frequently, but now we are trying to transition to managing it similarly to our other respiratory illnesses, so you're less likely to see it as frequent updates in the guidance as in the past. Being here today and being a part of our IPAC COP helps to keep your facilities and policies and procedures up to date. All necessary supplies are accessible and readily available for clients on precautions or an outbreak. We feel fairly confident that our CLSs have a good grasp on the importance of initiating protective measures quickly in order to stop or reduce the spread within their facilities. Having PPE available to deploy when needed will drastically help. Having a process in place to ensure PPE is not expired is also ideal, and ensuring signage is up to date, printed, and in protective sheeting so it can be put in place quickly. Next, you want to ensure staff involved are educated on case management changes. Case and contact management has changed a lot with COVID, and differentiating between COVID and other respiratory diseases is something many of our facilities haven't dealt with yet. Ensure anyone in this role understands but also feels comfortable and supported in their role. You also want to make sure your immunization records are current. This could affect who is allowed to work, where they can work, and if additional measures are required. Immunizations are often a part of a facility's policies and procedures as well. And lastly, but most important, is ongoing IPAC education for staff. Even if it feels mundane, many people want to forget they are burnt out or their new staff who may not have had a lot of experience or exposure. Routine education will ensure that these measures are adhered to and good habits are created. As we spoke to immunizations on the previous slide, there are some yearly immunizations that should be promoted with staff and clients in order to prevent case increases and outbreaks within your facilities. Currently, TBDHU is running their COVID clinic and also offering flu vaccines at these clinics. COVID vaccines are also available at pharmacies and with healthcare providers, and many of these places should be receiving or have received their flu vaccine for the season as well. Additionally, to note, the pneumococcal vaccine is available and encouraged for CLS adults that are over the age of 65. How to recognize respiratory illness. Part of preparing ahead of time and recognizing cases early is routine monitoring of respiratory symptoms. Typically, they can all present in similar ways, and clients should be monitored at least once daily. Common symptoms of someone with a respiratory illness can include one or more of the following: fever or abnormal temperature or chills, a new or worsening cough, shortness of breath, runny nose, congestion or sneezing, sore throat or difficulty swallowing, generalized fatigue, tiredness beyond normal, muscle aches or joint pain, gastrointestinal symptoms including nausea, vomiting, diarrhea, and abdominal pain, headache, or lack of appetite. When it comes to defining a COVID-19 case, there continues to be a case definition which helps to determine if there's a potential for COVID-19 to be at play. The definition includes one of the following symptoms being present: fever or chills, or cough, shortness of breath, or decreased loss of taste or smell. If a client is experiencing two or more of the following symptoms, this can also be indicative of COVID-19 and will prompt further investigation and measures. These can include runny nose or nasal congestion, headache, extreme fatigue, sore throat, muscle aches or joint pain, vomiting, diarrhea, nausea, or abdominal cramps. That brings us to testing. Any client exhibiting symptoms from the previous slide should be identified as possibly having COVID or another respiratory disease. They should be kept away from well people and placed on additional precautions. Testing should be offered to these individuals as they are still residing within a highest risk CLS. PCR testing is still the preferred method. If a rapid test is used, it is suggested to have a PCR also performed as confirmation, as a negative RAT cannot be used to rule out COVID-19, and the results, positive or negative, should not change the management plan for a symptomatic resident.
A confirmed outbreak in a congregate living setting is defined as 2 or more clients with a common epidemiological link, each with a positive molecular or rapid antigen test within a 10-day period. You don't have to report until you have 2 cases. However, facilities can still call when there is one and if they need additional support or have questions. It's important to note that with the new guidance, suspect outbreaks no longer exist for congregate living settings. It is also not required to report staff cases to Thunder Bay Health Unit. However, still important to monitor and assess the risk any staff cases have posed within your facility, and if there is a larger degree of spread or impact to the clients, again, facilities may still contact TBDHU for guidance. As we already know, early detection is critical. Always being aware of clients' wellness during these months is ideal to identify any illness or potential outbreak situations early enough and to stop them from spreading. Surveillance or wellness checks can assist on this when it is part of a routine practice. If frontline staff suspect there is an increase of symptomatic clients, they should report it to a designated staff immediately. There should also be a way for designated staff to track symptomatic clients, such as line lists, which we will go over next. A line list is a table that summarizes information about cases or illness within the facility. There should be one master list to ensure consistency. Anyone with symptoms which are not within their norm should be added to the list. Lab confirmation of illness is not required to be added. Staff and residents should be kept on separate line lists as well. Resident cases will determine if there is an outbreak and prompt a call to TBDHU, while staff lists will assist occupational health and internal management. Here is an example of a resident line list for respiratory illness. You'll see important information captured at the top, which includes outbreak number and facility. When adding residents to the list, be sure to put full names, as some clients may have the same initials or last names. If there are any shared rooms, ensure a bed number is added. Some will add a numbered list so they can refer to clients by their number and initials in emails in order to limit personal information disclosed through correspondence. And lastly, if and when any specimens are collected, ensure to input the date of collection on the list as well.
You have an increase in client cases. Now what? We have done the surveillance, wellness checks, and monitoring, and now identified there is an abnormal amount of clients who are ill with respiratory symptoms in a short period of time. What does that mean, and how do we handle it? We will be discussing this question and outlining the next steps of the process for how to deal with it. Outline for the next steps. For the next part of the presentation, we are going to discuss what steps all facilities should take when there are cases of respiratory illness within their facility. These steps include reporting to the Thunder Bay District Health Unit, putting additional precautions in place, creating a way to track ill clients. So an example of this is utilizing a line list, and additional IPAC measures, which include separating the well clients from the ill clients, PPE stations, staff reminders, and cleaning. Reporting illness. Respiratory illnesses were not typically reported to the health unit pre-pandemic. This was required during the pandemic to slow the spread in order to manage our healthcare systems. Moving forward, there is no longer a mandatory declaration of outbreak in our CLSs. The Ministry of Health and Long-Term Care expects a difficult season with respiratory illnesses. These include COVID, influenza, RSV, adenovirus, etc. However, we are also trying to get back to living with these typically more seasonal diseases and managing them as we continue our lives without further lockdowns. Therefore, the case and contact management nurses, your continued main contact here at the health unit, will continue with supporting you, and they will do a facility and case assessment with you, as you report an increase in cases within your facility or 2 positive resident cases. You can call the health unit at any time, but must call if you have 2 clients suspected or confirmed with respiratory cases. The health unit will decide if the facility and cases can be managed without declaring an outbreak. If the outbreak is declared, it is likely to protect those within your facility, and your facility can adequately manage it with fewer negative outcomes. If an outbreak is not declared, there are still measures that will be put in place instituting a more harm reduction approach. The health unit will help guide you through control measures and supply additional support, regardless if it's an outbreak or not. Routine practices. To prevent further spread of the infectious agent, it is important to put infection control measures in place. These include both routine practices and additional precautions. Routine practices are based on the premise that all clients are potentially infectious, even when asymptomatic, and that the safe standards of practice should be used routinely with all clients to prevent exposure to blood, body fluids, secretions, excretions, mucous membranes, non-intact skin, or soiled items, and to prevent the spread of microorganisms. Routine practices include hand hygiene and routine use of PPE, but also extend to other elements such as point-of-care risk assessment controls of the environment and administrative controls. The consistent and appropriate use of routine practices by all healthcare providers with all patient encounters will lessen microbial transmission in the healthcare setting and reduce the need for additional precautions. Specific control measures. When you have clients who are ill, specific and additional control measures are put in place quickly with the goal of preventing further spread. These need to be implemented as soon as the cases are identified. Additional precautions are used in addition to routine practices for clients, patients, or residents known or suspected to be infected or colonized with certain microorganisms to interrupt transmission. When it is a respiratory infectious agent or outbreak, the transmission-specific control measures will reflect in the ways in which the infectious agents can be spread. So either through droplets, so a cough or a sneeze, airborne through aerosol-generated medical procedures, used with CPAP or high-flow oxygen, or contact of an infectious person or their environment. Symptomatic clients. Additional precautions. So shown on the slide are the additional precautions at which PPE is required based on the mode of transmission. So for contact precautions, PPE requirements include gown and gloves. For droplet, it includes gown, gloves, medical mask, and eye protection. For airborne, it includes gown, gloves, and N95 mask and eye protection. A client is not limited to one of these precautions as they can be mixed as well, such as with COVID, the minimal is droplet and contact precautions. These additional precautions become the minimal requirements, and additional precautions based on a point-of-care risk assessment could be initiated. Additional precautions for rooms. Any symptomatic client should be isolated to their room with the door closed if possible to decrease the spread of droplets within the facility. Food should be delivered to them, and they should not attend communal dining. If the client is confirmed to have positive, then they must stay on precautions in their room for 5 days from onset of symptoms, and their symptoms also must be improving. So for 24 hours if it is respiratory symptoms, and 48 hours if any gastrointestinal symptoms, so vomiting or diarrhea or nausea from the last episode. This has the potential to extend the 5 days. After their 5 or more days, they should mask if it's tolerated within the facility till it is 10 days from the onset of their symptoms. If there are roommates of the positive COVID case, they should also mask if tolerated and be assessed twice daily for symptoms. No testing is required unless they become symptomatic. Clients exhibiting respiratory symptoms and test COVID negative only required to isolate until their symptoms have resolved for 5 days, whichever is shorter. The other way this is extended is if they are tested and are positive for another agent. That could extend their isolation. This is unlikely when thinking of your setting. It would only likely occur if they left the facility for additional health support, for example at the hospital.
Resident cohorting. Resident cohorting is another measure that should be implemented when experiencing an increase in respiratory cases in your facility. It is ideal for anyone experiencing symptoms to have their own room. Understandably, this isn't always achievable. However, if required, there's a limit of a maximum of 2 individuals in a room where one is ill. Cohorting of residents infected with or exposed to COVID-19 is a commonly used strategy for preventing its spread in congregate living settings. Many facilities have opted to utilize off-site isolation when on-site isolation is too difficult with staffing, behaviors, or facility layout. There should always be a facility plan in place for on or off-site isolation of residents. Bathrooms should also not be shared between the ill and the well. Assigned bathrooms or the use of commodes can assist in achieving cohorted bathrooms. If it is not possible, then cleaning and disinfecting between the cohorts should be done with each use. Special considerations. We are all aware that not everyone is going to be able to adhere to all precautions all the time. Clients within our facilities can be very unique, and we have to work with them in order to follow the protocols the best we can and continue to provide quality of life as well. Clients who are unable to stick to strict additional precautions within their room, especially clients who smoke, have dementia, or struggle with mental health, and those who are known wanderers, can contribute to spread within a facility, if not managed appropriately. The pandemic has assisted in creative thinking in order to balance adherence to measures and quality of life. It is always ideal practice to redirect individuals quickly and efficiently back to their rooms, ensuring staff have appropriate PPE to protect themselves during these interactions, and there is adequate staffing to support this, especially within facilities where this could be a larger issue. Encouraging those who leave their rooms to, at minimally, wear a mask is also an important measure to be put in place. If you have clients on precautions, dedicating a safe area for the client away from others in order to give them a break from their room is acceptable. if it can be done properly and monitored and adhered to. Some examples would be a dedicated smoking area away from those who are well, or one-on-one walks with staff or volunteers, or a sitting area dedicated to that person. Scheduling time for these to be done is also an option, ensuring proper high-touch surface environmental cleaning is being done following this. IPAC control measures. Now that we've finished discussing symptomatic clients, let's jump to our other IPAC control measures that need to be implemented when there's an increase of cases or an outbreak declared. First and foremost, communication is always key. Ensuring clients know what to expect, but also visitors to the facility, be it family, friends, or other healthcare personnel or agencies coming in. Signage, emails, or phone calls to families are all ways to provide this important communication. In addition to communication, we want to ensure you implement further measures such as hand hygiene, environmental cleaning, and of course, continuing education on all IPAC measures with staff, clients, and visitors. Teamwork is key during these hectic months, and ensuring everyone is on board will be a big help. Our first and one of our most important routine IPAC measures will always be hand hygiene. Hand hygiene is a routine practice that must be performed by all healthcare staff and visitors, whether they perform direct care or not, and should be encouraged and promoted with residents and clients as well. Effective hand hygiene kills or removes transient bacteria on the skin. This can be done by two methods. Hand sanitizing with 70 to 90% alcohol-based hand rub, which is the preferred method when hands are not visibly soiled for cleaning, or hand washing with soap and running water. The mechanical action of hand washing with soap and running water is required when your hands are visibly soiled. When it comes to hand hygiene and increased cases, any facility should consider the following. Ensuring your facility has adequate supply of alcohol-based hand rub and all other hand hygiene supplies for use during an outbreak. Making sure products are placed in the appropriate places throughout the facility for optimal use, such as outside client rooms, break rooms, dining areas, and ensuring that areas that are used only by staff still have alcohol-based hand rub available. There should also be someone assigned the responsibility of refilling the soaps and alcohol-based hand rub, as it is important not to run out or have any empty containers at any time. If your facility is unable to utilize alcohol-based hand rub for wall units or have it left out, you can utilize containers that are kept on person, ensuring staff have easy access to replace them when they become empty. Over the pandemic, there have been some lessons learned that we would like to share so we can learn from them and improve our practices. Some of the lessons that we've learned from, which can contribute to the spread of infections, include facilities not having sufficient alcohol-based hand rub or hand sinks available, lack of alcohol-based hand rub in wall units, or bottles missing from where they should be, or designated locations can lead to missed hand hygiene opportunities and spread within a facility. Sometimes it can be a difficult situation where alcohol-based hand rub cannot be left out within a facility. Using portable sinks may be required for client hand washing or if staff are unable to keep alcohol-based hand rub on person. ABHR not in the proper areas or inaccessible to staff. So if alcohol-based hand rub is hidden in areas not visible to visitors or staff, or in a poor location, or there's a lack of signage indicating where to find it, an individual is less likely to seek it out, leading to a misstep in hand hygiene and thus increasing the spread of infections. The misuse of gloves. If using gloves in instances where they are not required, or wearing them in replace of performing hand hygiene, the wearer will miss important moments of hand hygiene and will be contributing greatly to the spread of infections within a facility. Not to mention, it would also be putting the wearer and other persons directly at risk for infection. It's important to have all frontline staff watch and re-educate on hand hygiene before respiratory season and/or when outbreaks are declared. People are naturally complacent about most things in life. It's just natural. We are like water and we like to take the easy route. We all know we have to wash our hands and the certain moments that we should, but we also know the speed limit when driving. And despite that, many of us drove over the speed limit today and sometimes every day, even though we know it puts others at risk. That's why we have speed limit signs and officers who enforce these limits. Same goes for hand hygiene. That's why we talk about it, we relearn the practice, and have signage and have our own type of enforcement around it. Something so simple can prevent illness, thus saving lives.
Let's move on to PPE. PPE, or personal protective equipment, serves as an additional barrier to potential exposure of infectious agents and should be utilized appropriately depending on the care being provided at any time, not just an outbreak. This is what makes it part of routine practices. All care facilities must provide an adequate supply of easily accessible and appropriate personal protective equipment in order to prevent staff, volunteers, students, as well as visitors from any potential contact with blood and other body fluids, secretions, excretions, or non-intact skin. PPE includes the use of a mask or respirator, eye protection. This can be safety glasses, goggles, or face shields, gloves, and gowns. Just as an educational perspective, let's take a look at some lessons learned regarding PPE use. Throughout the pandemic, some things that we have seen which could contribute to increased transmission are masking, staff not understanding the use of masks as universal precautions versus use as PPE, and the steps on when to remove and change PPE to better protect themselves and their clients. Any interaction with a symptomatic client or a client on additional precautions contaminates any PPE you have on, and it must be changed after that interaction. Due to frequent guidance changes, this can become confusing for staff. It's important to ensure staff are educated and know the policies and how to perform a point-of-care risk assessment. Next, eye protection. Understanding how and when to properly reprocess and which product to use. For gloves, staff were found to be wearing gloves for activities that don't necessarily require their use. So, for example, screening, walking around the facility, or during training sessions. We saw many instances where staff would be wearing gloves throughout the facility while drinking their coffee, touching their hair and their cell phone, etc., missing many steps for hand hygiene and potentially contributing to the spread of infectious agents. Lastly, gowns were observed to be worn down the hallways to the doffing area that was placed incorrectly, or worn from room to room as they potentially lacked the knowledge that gowns should be single-use and not to be worn from patient to patient. Again, an indication for education and potentially assessing the placement of PPE stations. The mentality or thought process for many individuals who had been observed misusing PPE was that they were protecting themselves, which is very important, but unaware that they could be contributing to the spread throughout the facility and actually harming others and increasing their own personal risk. Last, just making sure any outside agencies coming to provide care for or visitors that require PPE have the appropriate training and adhere to the requirements. So, for example, visiting agencies such as VON or ParaMed, just making sure they're not entering the building with their full PPE already on, or grabbing breakfast or other items in their PPE, etc. So we've talked about PPE, but now we'll talk a bit about the principles of a PPE cart setup. PPE carts or stations hold all the necessary supplies required to implement additional precautions for residents or rooms. So for example, droplet contact precautions. The PPE station needs to be set up at the first sign of symptoms. This is at the very first symptom. You should not wait for the outbreak to be declared. Additional precautions which are put into place are based on the client and symptoms present, not the actual outbreak declaration. The additional precautions are meant to stop spread at the first sign. PPE carts or stations should be located outside of the room of a symptomatic client. For some units, placing a PPE cart outside the room may not be practical. Determine a location that is suitable and post a sign on the door where the client is isolating to communicate that PPE is to be worn and where the PPE is located, if not at that site. Garbage disposal location must be just inside the room or just outside to ensure dirty PPE isn't being worn outside of the environment, which of course can contribute to spread. Signage is required with the garbage disposal to ensure proper doffing of PPE. We will go into this a bit more in the next few slides.
PPE Station Set Up. The setup or arrangement of the cart itself can be important. Ensuring it holds all the necessary supplies, and those supplies are accessible yet kept clean. PPE should be stored in order to be protected from dust and droplets. We usually recommend drawer units or covered cart options as opposed to the open shelves. The over-the-door caddy does work as it keeps the supplies clean and contained. This should be placed on the outside of the door. If it's placed on the inside of the door, it will most likely be within 2 meters of a symptomatic client. The caddy should include a clean box of masks, gloves in various sizes, gowns, a way to reprocess eyewear, or somewhere to dispose of eyewear and new sets available. There should also be alcohol-based hand rub on top of the cart, so no moments of hand hygiene are missed. If this isn't possible due to safety reasons, it can be carried on person as well. There should also be access to environmental wipes too, to wipe down any shared equipment such as the blood pressure cuff or vitals machine. Ensure there's also staff that are dedicated to restocking those PPE carts. PPE stations and signage. Signage is also important in outbreaks, and reinforcing the importance of getting it in place as soon as possible is crucial. Prepare for outbreaks by having your additional precaution and outbreak signage ready to put up an adequate supply of them. Use of plastic sheet protectors are great, as the signage can be switched out if needed and the outside wiped down. Ensure the signage works for your facility. There's a lot of signage developed for long-term care and acute care, but it hasn't always been compatible with our other facilities. We have developed some signage at the hub, and is available on our website for you. If you find there is not adequate signage, we invite you to let us know what is lacking, and we can likely develop something for your use. Signs should always be bright and to the point. Bright signs are used to stop and catch your attention, and also differentiate between other daily signs. Signage should be direct so they are followed easily. Ensuring your facility has adequate signage and supply of signage and is able to have it in place quickly ensures less confusion and contains the spread more quickly. Signage for PPE stations should be put with the station or where the user can easily see it. Donning should be with the PPE station and doffing signage with the garbage can. This identifies what the stations are for and allows those to follow the instructions. PPE and garbage can placement. The last aspect is the garbage can placement. A garbage can should also be accessible right at the threshold of the room where doffing will occur. It should be ideally placed just within the door of the room, but if unable to place there due to space or patient safety, it should be accessible just outside the door, but never right beside the clean PPE caddy, as this is a risk of cross-contamination. Layout of your facility will determine the garbage can placement. Some of the lessons we have learned in relation to PPE carts, signage, and garbage are as follows. For carts, the placement can be too far away for where it is used for or not stocked with enough supplies. This confuses staff for what they should be following or increases risks to their safety going in without all the required PPE. Also, another lesson learned is lack of alcohol-based hand rub at these stations or on person, which would lead to missed moments of hand hygiene and increased risks of transmission. For signage, the lesson learned is signage not getting up, therefore not identifying where additional precautions are required. Another issue identified with signage was the doffing signage being placed with the PPE cart and donning instructions being placed with the garbage can. Again, this creates confusion and could result in a misstep during these processes. For the garbage, what we see the most is the garbage can against the PPE cart and dirty PPE touching the clean cart, which creates cross-contamination. There needs to be clear separation of the two. There have also been times where the garbage can is too far away, leading to individuals walking through clean environments that can result in spread. So these are just some of the lessons we have learned over time.
Environmental cleaning helps break the chain of transmission between surfaces and the client, either directly or indirectly through healthcare workers or staff. It breaks the transmission between the surfaces and staff as well. It is one of the many IPAC measures that can be layered together to provide a safe working and living environment. Environmental cleaning or housekeeping IPAC measures. Environmental cleaning measures haven't drastically changed. A facility should always be practicing cleaning and disinfecting routinely. However, high-touch surfaces should be increased to minimally 2 times per day when there is an outbreak or an increase of cases within a facility. Again, this is the minimal. We understand most of our facilities are well versed in environmental cleaning and typically achieve 2 to 3 times a day for their normal activity. Environmental cleaning is a supplement for when hand hygiene steps are missed or when symptomatic individuals were in a common area. Further increase to cleaning and disinfecting could be required when clients aren't fully isolating, so example, a wanderer, or when bathrooms are not private, or they're not cohorted, so shared between the well and the ill. Whenever possible, those providing environmental cleaning services should always move from the well person to the ill persons, meaning they clean the rooms and bathrooms of those who are not on precautions or who are well prior to the ones that are ill or on precautions. If there's a break in PPE or measures, this reduces the risk to the well clients. If someone was to clean an ill client's room, not remove the dirty PPE, and then clean a well person's room, there could be a transfer of harmful microbes and expose that well person. Environmental cleaning staff have the ability to infect other clients just as much as a staff member who provides care. PPE for housekeeping staff. Ensure proper PPE practices by all housekeeping staff. It may not be a process they use daily, and they may need to be refreshed when and how to do it. They should be educated at minimally yearly and refreshed on the requirements and processes anytime a facility is an outbreak or there's an increase of clients on additional precautions. PPE includes the use of gloves, gowns, eye protection, and masks when cleaning clients' rooms, and adherence to strict hand hygiene practices. For cleaner and disinfectant products, you need to have the proper selection of products to effectively kill or deactivate the infectious agents, and also ensure the proper process is being used for those selected products. Product knowledge is something that all facilities should be aware of after COVID due to the increased education provided around this. Always read the fine print. Ensure you have the right product. Environmental cleaning managers or employee with this role should be able to direct and choose these products for you. If you don't have one of these in your facility available, then you can utilize resources available to you. So this include our environmental cleaning education module on our Thunder Bay District Health Unit IPAC Hub website under our Champions program. You could also speak to a chemical supplier. You could call our environmental health department and speak to one of our public health inspectors, or you can connect with us at the IPAC Hub and we'd be happy to assist you. Laundry IPAC measures. So no major changes here on implementation within your facility. Just the major idea is that PPE for staff handling the laundry. So just like environmental staff, we want to ensure that they're re-educated on when and how to use PPE and that they have adequate access to PPE. Always reinforcing those good hand hygiene practices. Environmental services and laundry mishaps. Product misuse increased during the COVID, initially due to a short supply of products and then an ongoing issue of unfamiliarity of products. We experienced companies or suppliers marketing chemicals incorrectly, donating products for improper uses. We saw hand sanitizing wipes being used as sanitizing or disinfecting wipes for surfaces, disinfectants that weren't strong enough for what they were being marketed for, and expired product being delivered to our facilities. However, with education around environmental cleaning and your staff dedication to this knowledge, these types of mishaps have gone back down to the baseline we saw prior to the pandemic. The most common mistake or mishap is the use of a disinfectant as both a cleaner and disinfectant. You must read the fine print and the manufacturer's directions. Some products are both cleaner and disinfectant, while others are only one of them. If your product is only a disinfectant, you must go through and clean first. Some procedural errors. Not adhering to the contact time required for the disinfectant to properly work. So this could be not enough product being applied for the surface to remain wet, wrong methods of application, or the wrong concentrations being mixed. Not having enough trained staff or external contracts available can also be an issue in order to maintain the required high-touch surface and room cleaning schedules. So the more individuals you have on precautions, the more time and resources of staff will be required as well. PPE misuses. So gloves being worn between dirty and clean laundry, gloves being used for tasks when not required, such as pushing carts or sweeping floors, etc., or those missed hand hygiene moments due to glove use, and then the use of gloves for that false security. So that sense that you're protecting yourself, however, you are contributing to the spread throughout the facility if you're not taking off those gloves and performing hand hygiene. Reducing the spread. Additional measures that can be utilized to help reduce the spread within a facility include, but not limited to, ensuring clients are educated on any community guidance that is applicable at that time. For example, COVID positive clients should not visit other high-risk facilities within the 10 days after their symptoms started if it's not required for them to go. If it is required, such as an essential appointment, so perhaps they have to go for dialysis or a place like that, then they're going to practice masking and adhere to physical distancing at that facility. Typically, during outbreaks, non-essential visits are asked to be rescheduled. This also can be applied when you're not in outbreak if the measure is beneficial to protect the clients within that facility. So if you're seeing an increase of respiratory illness within your facility, you could always ask family and friends to consider doing an online meeting or visit, or postpone it by a few days. Adding IPAC measures, if those who continue to visit, is another option as well. So layering those IPAC measures approaches, ensuring good ventilation, masking, and physical distancing if the visitation continues. Shared items at communal dining, such as salt and pepper or ketchup shakers, can be discouraged, and use of single items supplied in place, so individual packets. This would help reduce the spread between clients and beneficial during a facility-wide outbreak. Wrapping any ready-to-eat items that don't have a thick peel is also beneficial, such as apples, pears, or muffins. Increasing hand hygiene in these areas, so any communal areas, is ideal as well. Ensure your utensils are placed with the handles up for self-service to ensure that the base where it goes into your mouth is not being contaminated. Multiple respiratory occurrences. The possibility we all don't want to be reality is the event that multiple respiratory outbreaks are occurring in one facility. The idea is you're going to manage each outbreak independently. So they'll each get their own outbreak numbers, and they will be discussed, and clients would be cohorted accordingly to what outbreak they're in. That wouldn't be amalgamated into one. So you're still going to manage the outbreaks separately. Obviously, there is going to be areas where they do overlap. So some examples for an outbreak of COVID-19 and influenza, there may be specific control measures for each virus to be implemented, so the cohorting or antiviral medication. There are going to be work exclusions for some, why not for others? However, basic IPAC measures would still be consistent throughout, so increasing hand hygiene and environmental cleaning, etc. So with these, you're going to work very closely with your local public health team to navigate through it. The key idea here is they're going to treat separately, obviously with measures of overlap.
Okay, so this brings us to the end of our session today. Let's just recap some of the highlights. Facilities should continue to maintain a Thunder Bay Health Unit point of contact. This will be the same contact as before, but now just to ensure coverage, one main email will be used, which is shown here in the slide at covidphn@tbdhu.com. Facilities should continue to report positive COVID cases to Thunder Bay Health Unit if meeting the outbreak criteria or if there are any questions or concerns outside of that. Facilities are required to report an increase or cluster of respiratory non-COVID client cases to Thunder Bay Health Unit and should ensure line lists are handy. Additional precautions should be implemented quickly on any symptomatic clients, not just confirmed positive, and staff should continue to perform point-of-care risk assessments with every interaction. Continued implementation of other control measures, such as hand hygiene, environmental cleaning, and cohorting, is important. Facilities should request additional support if required, such as on-site assistance with PPE carts, staff training, or disinfectant or cleaning support. Lastly, facilities in which an outbreak is declared will have additional measures in place, so for example regarding admissions, visitor restrictions, or otherwise. However, these measures will be discussed during the outbreak meetings and directed by the Thunder Bay Health Unit nurse.